Once again, good evening and a very warm welcome to our webinar on heartburn and acid reflux testing and treatment. My name is Louise and I'm your host this evening. I'm delighted to be joined by our expert speaker, Mr. Ahmed Hamouda, Upper GI consultant here at Benton Hospital. Tonight's session will begin with a presentation from Mr. Hamouda, followed by a live question and answer session. If you have any questions at any point, please feel free to use the Q&A icon at the bottom of your screen. You're welcome to ask anonymously or include your name. Just a quick note that the session is being recorded, so any names shared will be visible in the recording. If you're interested in booking a consultation, we'll share all the relevant contact details at the end of this session. Over to you, Mr. Hamouda.
Thank you very much, Louise, and hello, everyone. So moving on to the next slide. So I am an upper GI surgeon, which means I specialize in operating and dealing with conditions of the gullet, the stomach, and the gallbladder, as well as hernias. I'm duly qualified, so I qualified in Egypt and then also trained here in the UK, and I have a wealth of experience behind me. You know, very, very happy to see you for advice and consultations. Moving on to the next slide. So what we're going to do today is talk about GORD, and GORD just means gastroesophageal reflux disease. It's a very common condition, and I think that everyone will have experienced reflux at some point in their lives. Whether it's you know, a pregnant lady who will have some pressure increasing on the tummy causing reflux, or after a night out when you've had, you know, a curry or 2 glasses of wine, then that's what normally will happen, is you get some heartburn. But what we really want to focus on is heartburn that is problematic, that occurs almost on a daily basis, that needs to be looked into a bit more. So moving on to the next slide. So a bit about history of how it all happened and how it was first described back in 1925, when it was commented on and it was considered to be a condition related to a hiatus hernia, which is part of your stomach being pushed up into the diaphragm, above the diaphragm into the chest. And of course, these honorable gentlemen described it and rightly considered that it was caused by gastric acid. So moving on to the next slide. So reflux occurs because the acid that's normally in the stomach will travel up into the gullet. And there is a mechanism at the lower end of the gullet, a valve mechanism, that will prevent this from happening. Or even if it does happen, as soon as the acid comes up into the gullet, it should be flushed back down by esophageal motility, so the contraction of the gullet to shift things back into the stomach again. Initially, it was thought to be increased amount of acid in the stomach, but that's not the case. It's really because of the disruption of the valve mechanism at the lower end of the gullet. So moving on to the next slide. So it's quite prevalent. As I was saying to you before, I don't think that there's anybody who hasn't experienced it, even if it's very mild and occurs maybe, you know, once in a year or once in a lifetime. But it's considered to be clinically significant if the symptoms are occurring more than twice in a week. And the 2 typical presentations that you get are heartburn, which is this burning sensation behind the chest plate or the breastbone. And the other is a perception of fluid coming back up into the gullet and into the mouth, whether that fluid is acidic, whether it tastes not very nice, a bit bitter, or has a bit of undigested food. That's called regurgitation. So moving on to the next slide. Reflux can be caused by a variety of things. So, for example, smoking, being overweight, having a hiatus hernia, which means that the stomach and the valve mechanism has been disrupted and the stomach has been pushed up into the chest above the diaphragm. Eating large meals, we all know that if we have a curry or fried food, especially late at night, then we will get some reflux. And beverages, of course, and, you know, acidic things such as wine, for example, and stress. There are medications that can also cause it or worsen it, such as non-steroidal anti-inflammatory drugs, which basically means things like naproxen, diclofenac, aspirin, amongst other medications. Moving on to the next. So these are the less typical symptoms, and these are the symptoms that we normally ask in people who don't present with classical reflux and regurgitation. So dysphagia means food sticking behind in the gullet or behind the chest plate, a bit of pain in the chest generally, salivating more than normal. A globus just means a feeling of a blockage in the throat level or a feeling of a lump in the throat. Nausea, which is sickness, dental issues such as erosion of the back of the teeth, and a bit of spluttering or wheezing or coughing, especially at nighttime when people are lying flat and you get the regurg of the fluid back and aspirating fluid spilling over into the lung. Moving on to the next. So you can normally diagnose reflux and heartburn based on symptoms. And as I said, the typical ones are the heartburn and the regurgitation. So if that happens, and then you take something like omeprazole, which is a proton pump inhibitor, and that treats it, then generally we know you've got reflux. However, there are certain tests that may be required, especially if there's any alarm features or risk factors for Barrett's. Now, Barrett's is a term that means that the lining of the gullet has started changing to what normally lines the stomach. So the lining of the stomach is creeping up onto the gullet, and that's called Barrett's. It's quite important, and I'll get to that in a second or two. Moving on to the next. So these are the indications for evaluation. If we have reflux and heartburn, and then there's obviously a new onset of indigestion, especially at 60 years or after. If there's any evidence of bleeding or anemia, if we have weight loss and anorexia, which means we don't really like food as much, or food is sticking, or there's pain on swallowing, vomiting, or cancer in the first degree relative. The alarm features for Barrett's, for example, are a duration of reflux of at least 5 to 10 years, ages more than 50 years of age, males, hiatal hernia, being obese, using tobacco, and reflux that happens during the nighttime. Moving on to the next one. And really, when you come and see me with these symptoms and some of the alarm features or one or two of the alarm features, I will be thinking of doing an endoscopy straight away. An endoscopy is a camera and done under sedation and local anesthetic, and it travels down through the mouth into the gullet, the stomach, and the first part of the bowel. And what I'm trying to look for is if there's any inflammation of the lower end of the gullet, if there's evidence of a hiatus hernia, if there's any Barrett's, which again, remember we said was a change in the lining from the lining of the gullet, changing over to what lines the stomach. So that's the first test. Now, if that shows us things that indicate and are suspicious for reflux, then we move on to manometry, which basically means that I'm checking the condition of the muscle of the gullet to see whether it's moving in a coordinated fashion. And those are a set of conditions called motility disorders, followed by pH monitoring. pH is really the crux of it for people like myself, surgeons. Because I need to have something that stays in the gullet for a period of time, say 2 or 3 days, 4 days maybe, to measure if acid is actually coming up into the gullet and how much that acid is. So quantify the amount, quantify the duration, quantify when it occurs during the day or the night, and that is called pH monitoring. And this is really what I want to talk to you about a bit more today with the Bravo capsule, which we are now very lucky to have at Benedin and very lucky to be able to offer to you as a diagnostic test. Other studies, so barium is when you drink some dye down and we do an x-ray and basically we put you in a head down position and see if any of that dye goes back into the gullet from the stomach, so whether there's any reflux. And a CT scan may be required just to look at the anatomical features of this area. So moving on to the next slide. So we're very lucky to be able to offer Bravo, and this has been available for the last 2 months. It is a quick procedure. It's done in the endoscopy unit. It's done under local anesthetic and sedation. You come in, we obviously admit you, put you on the trolley, and start with the endoscopy to check. So we're doing an endoscope first to check that everything is okay. And then we pop down with this probe that you can see on the right-hand side. It goes down into the gullet. We will normally place it about 1 inch or 2 above the junction between the gullet and the stomach, and then suck it onto the lining of the gullet so that it sticks there for anywhere between 2 and 4 days before it falls off on its own and just comes down through the bottom end. It is then, when it's attached, it will, by telemetry, send signals to a tape recorder or a device that you hold onto your belt, and it will record all those acid reflux episodes that I was talking about previously. Moving on to the next. And this is how it looks on the inside. So you may recall the picture from the last slide. The probe goes down into the gullet. It's sitting about 1 inch to 2 above the junction between the gullet and the stomach. And the middle picture shows that it's been suctioned onto the lining of the gullet, and it sticks there with a pin, a very small pin. And then on the third picture on your right, it's transmitting, obviously, to the tape recorder device for a period of 2 to 4 days. And then you send us the tape recorder device so that we can analyze it through special software, and it can tell us whether there is a real quantifiable acid reflux problem. Moving on to the next. So going back to Height's hernia, because of course Height's hernia is one of the conditions that is, highly suggestive of there being reflux. As a result of the stomach moving up into the chest, it disrupts the valve mechanism that I was talking about previously in the junction between the gullet and the stomach. And as a result, you get quite a bit of reflux. What you can see here on these two pictures is the camera, which is the black rod coming through the gullet and going into the stomach, and the pit that is around the black rod, the two pits that you can see there, are the Height's hernia. So that's where the stomach has been pushed up. It shouldn't really be a pit. It should just be a very snug area around the black rod, the endoscope. So moving on to the next. And here I'm going to try and explain to you what a Height's hernia means. So if you look at the picture on your left-hand side, if you look at the white dot, that represents the junction between the gullet and the stomach. The white dot is sitting at the diaphragm. This is normal. This is the normal configuration that we are all born with. The next picture to the right, which is the sliding Height's hernia, you can see the black dot has moved up above the diaphragm, and it's pulled a bit of stomach up with it. This is a sliding Height's hernia, and this is the most common one. Moving on to the type 2, the rolling. The white dot is where it's supposed to be at the diaphragm, but a bit of stomach has pushed up alongside of it, and that's a rolling Height's hernia, very rare. And then the last one, the mixed one, is where you get a combination of both. The white dot has moved up, so it's pulled a bit of stomach with it, but also there's a bit of rolling stomach to the side of it, and you get a mixed type, both occurring at the same time. Moving on to the next. So reflux is a problem. Why is it a problem? Because if your gullet is exposed to acid for a period of time, a prolonged period of time, it can lead initially to inflammation, which we call esophagitis. That's the first term that you can see there, reflux esophagitis, yeah? Now, reflux esophagitis, again, if that acid burn continues without it being treated somehow, it will start causing ulcers, erosions. The whole area will become quite inflamed circumferentially all around, and then it can stricture, so it can narrow, leading to problems with eating and drinking where you feel very tight, and it can change into Barrett's. Remember, Barrett's, we said, was a creeping of the stomach lining onto the gullet where it's not supposed to be. Once we see it on endoscopy, we take biopsies, because the thing with Barrett's is if you leave Barrett's for a long period of time, there's a possibility it can change. Now, the rate of change is quite small, so say 2 to 3% of people with Barrett's will change into something that's a bit more serious and sinister. And that's the fourth term that you have on the slide there, which is the adenocarcinoma. It can also, with reflux, it can cause inflammation of your larynx up there, and it can spill over into the lung and cause a pneumonia. We call it aspiration pneumonia. Moving on to the next. So here you can see the classification of esophagitis. Remember, we talked about inflammation. We said that if there was acid burn to the lower end of the gullet, you get esophagitis, inflammation. So the first picture on your left-hand side, that's grade A. You can see a single streak there. So if you get 1 or 2 streaks only, it's grade A. Grade B, you get 2 or 3 streaks, and the streaks are slightly longer, and they look a bit reddish, more red and more inflamed. grade C, you move on to there, and you can see that about a quarter of the circumference there is quite red and hot and inflamed, with some streaks as well. And then grade D is almost the whole circumference is quite red, and you can't actually appreciate it here because there is white areas on top of those ulcers. They're called ulcer sloughs, basically. But the whole of the circumference is actually quite inflamed. So moving on to the next. And again, here you've got the complications. So Barrett's is this salmon pink patch that you can see on the left-hand side. It's almost like the lining of the stomach, which is lower down there in the pit, is creeping up onto the gullet, and you can see that tongue is going up into the gullet. And when we see it, we call it Barrett's. We have a classification for it, but we also have to take some biopsies. And of course, if you have Barrett's, it may be that you need biopsies every 2 to 3 years to make sure it hasn't changed into something a bit more serious. The middle one, unfortunately, things have changed, taken a sinister turn, and it's become a bit of a swelling, a bit of a growth, a bit of a tumor. And you can see that there's a fleshy protrusion into the lumen of the gullet. And on the right-hand side, that's a real tight stricture. It's become a pinpoint, a hole. The black hole is basically all that you have to allow food and drink to get into the stomach. So it's become really tight and strictured. Moving on to the next. So we've made a diagnosis. We've gone down with the camera. We've done the Bravo capsule. We now know that there is there's reflux. We have a reflux problem, GORD. There's 3 things really that we can do. 1 is lifestyle change. 2 is start to use medication. And 3, in certain cases, we start thinking about surgery. What can you do to change your lifestyle to actually change the course of this condition? Well, you need to use gravity. Because we know that there's a leaky valve at the lower end of the gullet, what we're trying to do is get gravity to flush that acid back down into the stomach where it belongs. So if you're eating, eat really early in the evening, don't eat late at night, and then make sure that you're not lying down for 3 hours after you've had your dinner. And if you do lie on the left-hand side, raise the bed by putting 2 or 3 pillows so that you're, again, utilizing gravity. Your head is higher than your stomach, rib cage area. Lose weight, of course, goes without saying. The less pressure there is on the abdomen, which is the central part of your tummy, the more that you will be able to use gravity to flush the acid down. And avoiding foods, this obviously is very important. So avoiding the foods that give you symptoms, and everybody's different. So you will have foods and foodstuffs that are different from anybody else that give you reflux. You need to know what your foodstuffs are and try and avoid them. And of course, smoking as well. And to add as well, one more thing, stress. If you can manage stress in your life, I know very difficult to do, but if you can do that, then it does help. Moving on to the next. So if lifestyle modification hasn't worked for you, what will happen is you'll go and see your GP, and they will probably most likely put you on a proton pump inhibitor. And that is a drug like omeprazole, lansoprazole, esomeprazole. Those are proton pump inhibitors. They're known to decrease the amount of acid in your stomach. That's how they work. They decrease the amount of acid produced by your stomach quite significantly. So we're talking 80 to 90%. And so in effect, it's decreasing the amount that can reflux back up into your gullet. And that's how you get relief from your symptoms. We used to use H2 receptor blockers many years ago before they discovered proton pump inhibitors. They're still around. So drugs like famotidine, for example, which are very good. And then antacids. So everybody's used Gaviscon and Reni once or twice in their lifetime. And what they do is they just they line the gullet. So they don't actually go in the bloodstream. They just line the gullet. They coat it to prevent the acid from getting to the lining of the gullet and causing the symptoms. However, you will read there at the very bottom, the overuse of acid suppression is a problem because of the side effects and the costs. So what happens if we have somebody who is using medication but requires increasing doses to control their symptoms? Or, for example, is non-compliant. They have a very busy lifestyle, they forget to take their medication, or they're always traveling and it's quite difficult to obtain the medication or take it. Or, for example, they're worried about the side effects of taking omeprazole for a long period of time. And that's when they come and see me, because that is when we need to consider whether we're going to move on to the next stage of treatment. Moving on to the next slide. So before we go to the surgical side of things, we're just going to mention very quickly, and I think obviously I'm not going to read the slides for you, but foods that can trigger your symptoms, things like fried food, chili powder, fatty meats, and other foods that are acidic, tomato-based, citrus fruits, etc. We have another slide which tells you which foods, so the next slide, which foods can try and help your symptoms. So your good foods are high fiber foods, alkaline foods, watery foods, and homemade remedies with no scientific evidence. I don't advise people to try this, but you know, if milk does help and it tends to coat your gullet when you've had reflux, then by all means use milk as a way of treating your symptoms. And then moving on to the next. So lifestyle modification, you've tried it, it hasn't worked, you've gone on to medication, you're on omeprazole, you need 2 doses of it a day, but still you're not happy because you get breakthrough symptoms, or you forget to take your medication every day, or for example, you are worried about side effects. And of course, decreasing acid in your stomach means that we are also decreasing the ability of the stomach to absorb certain foodstuffs and nutrients, and that is where the long-term effects can happen. So you come and see me, and we discuss a procedure called a laparoscopic fundoplication. And what that means is we're trying to recreate the valve that has become leaky at the lower end of the gullet. It was described by Rudolf Nissen many years ago, and he first performed the procedure in 1955. Essentially, it's a complete 360-degree wrap of the stomach around the gullet. Some people do a partial wrap, and I would only really consider doing a partial wrap in people who have esophageal motility problems. So if your gullet isn't moving as effectively as it should do, then I would only give you a partial wrap, because I would be worried that if a complete wrap was there, food would stick and your gullet wouldn't be effectively able to push things through that complete 360-degree wrap. And the most common indication, as I said, failed lifestyle modification and medical management. It also is really important to consider it in people who have obviously complications that we talked about. So the esophagitis, the strictures, the ulcers, all of those things would warrant. And if you have Barrett's, well, guess what? Yes, you may need to be considered for surgery, but surgery does not cure Barrett's. So your Barrett's won't be cured by having the surgery. We're hoping that the surgery will stop its progression, will stop it getting worse. Will stop it getting worse. So that's the indication in Barrett's. Moving on to the next. And this is how surgery is done. It's keyhole surgery. It's a laparoscopic procedure. And essentially what I'm doing is dissecting the stomach. If you have a Hiatus hernia, I'm dissecting the stomach, making sure that it's brought back into the abdominal cavity where it belongs. And then the next stage is to put stitches into the diaphragm to make the diaphragm quite snug around the gullet. And then the third stage is taking the fundus of the stomach, which you can see here, the floppy bit of the stomach, going behind the gullet 360 degrees and back onto itself with stitches that are non-absorbable. So the stitches don't go away, they don't dissolve, they stay there. And it's designed for that area to just remain as a sort of a constriction ring around the lower end of the gullet. Moving on to the next. It's a 2-part procedure. We talked about the gastric fundus being wrapped around the lower end of the gullet. And I've talked, so the first part is what I mentioned before, which is part 3 actually. And then the second paragraph is part 1, which basically means that I have to treat the hiatus hernia first, bring the stomach down. That's first stage. Second stage is to treat the hiatus itself, which is the hole in the diaphragm. I have to make it snug around the gullet. So put a few stitches into it and then wrap the fundus around the gullet. So next slide. And you can see here, this is an operation that's already been done. And what has happened here is there's an X-ray with barium. There's dye that's going down through the gullet. And as it comes down to the lower end of the gullet, so look at the picture on the left-hand side, as the dye comes down to the bottom end of the gullet, it goes through a narrowing. And that narrowing has been created by the fundus, the fundoplication that we talked about, the wrap. So if you look at the right-hand side, it's describing the X-ray image for you there. So that wrap is actually constricting the lower end of the gullet and creating a valve, or recreating the valve that we've lost, because of course that valve should have been there anyway. But it's been lost, so we're recreating it. Next slide. So how effective is fundoplication? Well, if you look at the last point there, the research shows that at 10 years after you've had a fundoplication, almost 90% of patients were still free of significant reflux. And when I see patients in clinic, I talk to them about reflux in terms of the long term. So if, for example, you had significant reflux and you were refluxing every day, you needed 2 doses of omeprazole a day to treat it. And sometimes during the nighttime, you go and have some Gaviscon. Following the surgery, 5 or 6 years down the line, if you just need Gaviscon once a month, then that is a great result. It may never be 100%, but if it was 90%, 95%, then we have obviously, moved a long way from where we were before. It is definitely superior in reducing acid reflux in comparison to medical therapy on its own. And the partial fundoplication, you remember I said to you, this is really to minimize the problems that are related to the inability of the gullet to move quite effectively. So any motility disorders, we need to make sure that we do a partial rather than a complete wrap, because that might be a bit too tight. Moving on to the next slide. Once surgery's been done, of course, you are much tighter in that area. So as a result, burping is less. There's more gas that stays in the stomach. Therefore, there's more possibility of bloating and more possibility of flatulence down the bottom end. The wrap itself is quite tight. So when eating and drinking, especially eating, perhaps maybe steak and bread, you may feel that it sticks just above the wrap. And that's why there's certain recommendations following surgery. So eat little and often, chew your food very well, have small mouthfuls. And for the first 2 weeks after surgery, you're really on a liquid diet, followed by a soft diet before you go on to eating solid food. There's a small possibility of scarring in that area or damage to the vagus nerve, which controls bowel motions. So it could be a bit on the loose side following surgery for a period of time. And pseudoachalasia just means because the wrap is very tight, your gullet then stretches out to form almost like a new stomach, trying to push things through that wrap. Moving on to the next one. There are other treatments for esophageal reflux. We don't offer them at Benetton. However, some people have tried radiofrequency energy to the lower end of the gullet. What that does is it thickens the muscle at the lower end, and as a result of the thicker muscle, it tends to create almost like a valvular effect. It becomes a bit tighter in that area. And there's a device called the transoral incisionless fundoplication, which you can see on the right-hand side. And essentially, that's a device that staples the lower end of the stomach to the gullet, creating almost a V shape, which again is responsible for creating a high pressure zone in that area to prevent reflux. So next slide. So in summary, reflux is a common GI complaint, and I think that a lot of people will have suffered with reflux at some point. You need to only really worry about reflux if you're getting it more than twice a week. And if you do get it twice a week, you have tried both your lifestyle management and your medication, and it still hasn't worked for you, then please come and see me, and I can start investigating with endoscopy, Bravo capsule, which we can offer in our endoscopy unit, which is JAG accredited. And then we can talk about the options. If the options are surgery, then of course we can do a full appraisal of surgery, the risks, pros, cons, and take you through it basically and see whether that's an option for you. Thank you very much for listening to my presentation.
Thank you very much. That was very insightful and really interesting. So now we will go through the questions. We already have lots sent in, and quite a few are around the subject of omeprazole. So I think people are asking about the side effects. Should they take it every day, long-term effects, and any connection to dementia?
Omeprazole is one of those drugs that you either love or hate. So it has been in the news, and there's lots of reporting about it. So we know that it decreases acid in the stomach. And as a result, we know that there's certain things that don't absorb as well. So, B12 absorption may be affected, calcium absorption may be affected. There may be a long-term effect of osteoporosis. Dementia has been suggested, but I personally don't know if there's any evidence to show that it's linked to dementia. Um, and generally speaking, I know people who've been on omeprazole for a long period of time. So, it is a safe medication, but it's just the long term. And we don't have enough evidence at the moment to be able to tell you, but it is conceivable that there will be a long-term effect.
Thank you. Okay. In your presentation, you were saying about laying on one side versus the other, and we have a question about why is it worse when I lie on my right side in bed?
Again, it's gravity. So if you think of it, if the stomach is pressing down on the gullet, for example, or you're allowing the stomach content to flush up into the gullet easier, then that would be why. However, if you're on the side, which means that your gullet is, the junction of your gullet and your stomach is at a higher point than the floppy bit of the stomach, the fundus, then again, gravity will hold the fluid down in the floppy bit and not allow it to go in and flush into the gullet at the top. But again, I mean, it's not a guarantee. You could lie on both sides and still get reflux.
Thank you. Um, Anonymous attendee has been told that betaine hydrochloride with pepsin helps acid reflux. Is this true? And if not, what effect does this have on the body?
So I'm not entirely sure. I don't have any evidence to back this, but I think that it's one of those remedies that has been suggested in our slides as home-based remedies.
Mm.
So I'm not too sure that that helps in any way.
Okay. Um, Someone says, can we talk about burping, please? After eating at night and on exercise are their worst times.
Burping. So there's a condition called supragastric belching, and it's slightly different to reflux. So if it's just burping that's the issue, and there is no acid burn with it, there's no sensation of burning behind the chest plate, then unfortunately it's not one of those conditions that can be treated by surgery. And it's more, I think it would more be related to things like motility, for example, and we would need to consider maybe seeing someone to talk about medication.
Okay. Ready for this? This was quite a long question. So this person was diagnosed with Barrett's at the age of 25. This was brought under control, but they've recently had a dreadful 8 months of regurgitation, food sticking, agonizing spasms in the middle of the chest. They had an endoscopy done 2 months ago. No Barrett's was seen, luckily, and the biopsy showed as chronic gastritis. They can barely eat and do everything they should. The bed's raised, no alcohol, no late night eating. They take PPIs, but they don't work at all that well now. No testing's been offered past the endoscopy. Tested negative for H. pylori.
Pylori, yeah.
Yeah, and so therefore assume surgery would be the only option now.
Well, it's obviously congratulations on getting the Barrett sorted out, because that in itself is a win-win situation. I'm sorry to hear that this person is still suffering from symptoms. It is one of those complex conditions, and I think that there's quite a bit of complexity behind the presentation that you've just mentioned. So I would really be able to say, once I've seen everything, all the investigations of the endoscopy, I don't think that the surgery is necessarily the way forward, but certainly we just need to look at it, what's been done so far and what can be done in the future to try and get to a diagnosis.
Thanks. Is Barrett's hereditary? Someone said.
Not that I'm aware. Again, we are talking about a condition that happens as a result of acid burn to the lower end of the gullet, and what the stomach is trying to do is protect the gullet. So, in essence, it happens to anybody who has reflux, and that in itself is not a hereditary condition.
Um, Someone says, occasionally my reflux wakes me up at night. My mouth is full of saliva and it makes me vomit. Is this serious?
Well, it's only serious if you think that the symptoms are serious and if you're concerned about it and it wakes you up at night and obviously you're not getting a good night's sleep. So I would potentially say, when you say serious, it's not sinister, but it's serious enough to warrant investigation and possibly treatment. So again, I would encourage you to come forward and be seen.
Yeah. Is reflex stop any good?
Reflex stop. So again, I think you're referring to an endoscopic procedure, which is very similar to what I presented, which is the transoral incisionless fundoplication. I believe that's what it is. I'm not too sure because obviously the name could be a trademark name.
Mm.
But certainly, yes, if that's what you are mentioning, then yes, in refluxers, it can help treat reflux.
Is TI fundoplication better treatment than a Nissan fundoplication?
So TI is transoral incisionless fundoplication. We mentioned it on the last slide.
Mm.
It has been around for much less years than laparoscopic Nissen. Nissen has been around since 1955, you may recall from looking at those
Yes.
slides. So we have a lot of evidence in terms of the Nissens. We don't have as much evidence for the transoral incisionless. So I would say you're comparing new with old. It is a good procedure, but I wouldn't say it's the same as a laparoscopic fundoplication. No.
Thank you. Can hernias be cured with, is it Lucuro? Lqoro? Or is it
Lqoro,
Icaro? Icaro?
Icoro,
Hmm.
Icoro. I'm not sure, but I know that hernias can only be treated by surgery, so I'm not too sure what that is referring to. Sorry.
Yeah, it's a fair point. Um, Beth says she has had a heavy chest sensation every single day for the last 10 months. Her GP is finally saying it could be a silent acid reflux or a hernia. But is this a normal symptom?
No, that would be one of the atypical symptoms. So we talked about, remember, typical and
Yeah.
atypical. We said typical was the heartburn and the regurgitation, quite classical. And then you've got all the atypical symptoms, which are the globus, the erosion of the teeth, the sensations in the chest, etc. But again, I would say come forward, have
Mm,
an endoscopy done, because at the end of the day, nobody's going to know until you have an endoscopy, a camera.
yeah, seems a common theme. Um, when you have a gastroscopy,
Yeah.
do you use throat numbing spray?
Yes, so gastroscopies, we offer two things. We offer throat numbing spray, which is the local anesthesia, and that's normally the best way of getting the camera down because it tends to dampen down your gag reflex. And then obviously for people who are slightly anxious as well, we combine it with sedation, which means we put a needle into the back of your hand and give you something that calms you down, makes you slightly drowsy during the procedure. It's not a general anesthetic, but it is a sedative. So yes, we definitely do either one or a combination of both.
What's the difference between omeprazole and lansoprazole?
So omeprazole, lansoprazole, esomeprazole are all the same type of drug. They're proton pump inhibitors. They work on the proton pump, which is a small receptor in the lining of the stomach, and it shuts down acid production by about anywhere between 80 to 95%. So it's quite an effective drug in decreasing stomach acid and treating reflux symptoms.
Alexandra takes a low dose of aspirin every day because she's not keen on taking omeprazole every day. Is Alka-Seltzer in small doses a better alternative in terms of less acid reflux?
Alka-Seltzer is probably the same as Gaviscon and Rennie in terms of trying to get rid of the effects of acid reflux on the lining of the gullet. But it's not the same as proton pump inhibitors or H2 receptor blockers in terms of the efficacy. If you're taking a small dose aspirin, then with a bit of food, there shouldn't be really a problem. You wouldn't need to take any medication with it, acid medication, I meant.
Two questions around PPIs. One, are they linked to tumours? And two, would you have to come off your PPI whilst doing the Bravo test?
Yes, the answer to that is you need to come off your PPI so we can get a realistic measure of how much acid comes up into your gullet, definitely. And we'll give you all the information around the test itself when you come to see us. But the first part of the question, sorry, Louise, could you repeat the first part?
Are they linked to tumours?
No, not that I'm aware. No, there's no evidence that I've seen that they're linked to tumors, no. As in causing tumors. They don't cause tumors.
Yeah,
No,
yeah.
no, not that I'm aware.
Cool. Um, so what else we've got? It's quite similar questions, just trying to find some different ones. What is the role of friendly bacteria in treating acid reflux?
So friendly bacteria, again, we're talking about gut microbiome, and obviously that is a big topic, which I think is quite useful to mention. In the context of reflux, I do not particularly think that um, altering the gut microbiome is going to have much of an effect on reflux. Only because most of the gut bacteria are in the so small bowel and onwards, not as much in the stomach and not as much causing an element of reflux. So I think the jury's out on that one.
Hmm. Okay. Is a chronic cough associated with reflux?
So if you're lying flat at bed at nighttime and you're waking up in the nighttime with spluttering, you feel that there's some water in the back of your throat or mouth, you're spluttering, you're coughing, then it could well be due to reflux. But if it's not that sort of presentation, then chronic cough could be due to a variety of other things, of course, chest infections as a result, or asthma, etc.
Mm.
So it needs to be looked at and just maybe diagnosed within the context of reflux.
Okay. Related to that, this lady has been on PPIs for over 20 years. Reflux is well controlled apart from the cough, which is severe. It is during the day, rarely at night. Would fundoplication help with this, as it's been suggested it wouldn't? Also, Bendon will Bendon offer the reflux stop at some point?
Right. So at the moment, we're not offering the reflux stop, so that we can get that part out quickly. The second bit, which is, remember we talked about the atypical symptoms. Chronic cough is one.
Mm.
What you need to do is come and see us, because if you've been on the PPI for a long period of time and you have chronic cough, it's not really being treated well, you're spluttering at night, you need an endoscope and possibly a Bravo capsule test, and then we can sit down and talk about whether there's an issue with reflux. Those two tests will tell us. If there is an issue with reflux, then we could consider surgery, but if there isn't, then surgery would not really help your chronic cough.
Okay. Um, this person has been diagnosed with hiatus hernia and a Scatzy
A Shatsky ring.
ring. I regretted
Yeah.
us speaking that. Could you explain what it is?
Right. So you may recall from our slides earlier, when we looked at the inflammation of the lower end of the gullet, we called it esophagitis as a result of reflux and acid burn. Now, if the inflammation starts forming a stricture, that is called a ring, a Shatsky ring. So before it becomes a really tight stricture, it is like a fibrous ring, so a ring of fibrous scar tissue, and that is called a Shatsky ring. Normally, Shatsky rings aren't too much of a problem because they are not tight enough to decrease the lumen significantly to prevent food from going through. But it is on the way to becoming maybe perhaps something worse if reflux continues.
Slightly longer question to prepare for yourself for. They don't have symptoms suggested for AR, i.e. burning behind rib cage. However, they've been told by the doctor they may have reflux. Our teeth are wearing away with no bad diet plus coughing. They
Yeah.
also suffer pain in stomach, usually lower part when eating greasy foods, and when wake up or eating food containing sulfate. Now they regularly take omeprazole, which leaves them less bloated and minimal stomach pain. Would it be worth having an endoscopy?
I definitely think so. Yes, the answer to that question is yes. Of course, again, it's all going back to those two crucial slides that we talked about at the beginning. where there are a group of people where we know it's classical reflux. They've got the heartburn, they've got the regurgitation, they've got a Hiatus hernia and esophagitis on an endoscopy. And then you've got the people that have atypical symptoms that don't really present with typical reflux symptoms. Example such as the one that you were talking about, Louise. And in that
Mm.
case, the only way to find out is to do an endoscopy and maybe follow on with a Bravo capsule and see whether there is a problem with acid coming up.
Can acid reflux also cause a blocked nose?
Again, if it's causing catarrh, congestion as a result of inflammation of the oral pharynx, then yes, it can. Again, atypical symptoms. Normally, people will have gone to see an ENT, a doctor, and they will have had some investigation. They come to us, and they'll be told by the ENT doctor as well, maybe consider reflux and look into it and try and get a diagnosis. So, again, it's atypical, and again, I think an endoscopy would be quite helpful.
Um, Marion says you haven't mentioned pantoprazole.
I'm very
Um,
sorry.
she was taking emsoprazole, but it was changed by her GP.
So again, going back to proton pump inhibitors, I did say omeprazole, lansoprazole, and esomeprazole, but I did not mention pantoprazole.
Okay.
Pantoprazole is the fourth brother of omeprazole, lansoprazole, and esomeprazole. They are all proton pump inhibitors. And normally what the GP will do is if you don't respond to one, they will put you on to the next one, and so on and so forth until you've tried all four of them. And then if they don't work, you go on to the H2 inhibitor, which is famotidine. So, there's a lot of medication out there that you can try, but essentially, if it's not working, come in, have an endoscopy, and let's see if you have a genuine acid reflux problem that needs to be treated.
Yeah. With the Bravo, how can you be sure that it's actually come out and are there any side effects when it's inside you?
So it is a very minimally invasive procedure. It is done by sucking the lining of the gullet into a tiny little hole and putting a needle through. It's a tiny little needle. After a period of time, anywhere between two and 4 days, that area then just, sort of sloughs off, which means it just turns very mushy and soft, and the probe falls. It's a tiny probe. It's really smaller than, I would say, half an inch, and then it just comes down through the bottom end. Side effects of it, well, very little in terms of side effects to mention, but the side effects are really related to having the endoscopy, which is things like minor bleeding and perforation. Um, but some people have said that they can feel the Bravo sitting in their gullet. And if that's the case, then normally a bit of paracetamol will treat it for a day or two until it falls off.
Yeah, thank you. Um, Someone said, could we see the food triggers and help us slide again, please? But you will be sent the slides after the presentation, so you'll be able to see it then. Let's just go for one last. We have many more questions, but let's just go for one more, and then we can answer
Yeah.
others afterwards. Is a heavy, tight chest a typical symptom of acid reflux? This person experiences a heavy chest every single day before and after eating and when laying down at night. Is this a symptom that is worrying or not common?
Again, atypical symptom, and you may recall the slide where I said chest pain, so generalized chest pain, any type of heaviness in the chest. It could be a Hiatus hernia that's collecting food and causing a bit of compression, especially after you've had a meal, because it sounds like every time you have a meal, you have this symptom. And I just, again, would say that, doing an endoscopy would be quite helpful to try and figure out what's going on. But it's not worrying as such. It's not sinister. It's just that it needs to be diagnosed.
Okay, so thank you for all your questions and being part of this evening's session. If we didn't get to answer your question and you provided your name, we'll follow up with an email shortly and you'll get the answer to your question. As a thank you for attending, we're pleased to offer 50% off the value of your consultation for a limited time, a call back from our dedicated private patient advisors, an email with a recording of this session with all the slides, the treatment information, and some loyalty reward points for joining, and updates on future sessions and health news. We'd also really appreciate it if you could take a moment to complete the short survey at the end of this session, as this helps us to improve and tailor future webinars to your needs. If you'd like to speak to someone or book a consultation, our private patient team is available until 8:30 p.m. this evening, and it's available from 8 a.m. to 6 p.m. Monday to Friday. You'll find the contact number on your screen. We also have upcoming webinars on a range of topics, including cataract surgery, sleep problems, asthma, and orthopedics. And you can sign up to these via our website. So on behalf of Mr. Hamouda and all of us here at Benton Hospital, I'd like to say thank you very much for joining us today, and we'll hope to hear from you soon. So take care and goodbye.
Bye bye.